Welcome to This Explainer. Today, we're going to absolutely master the exact step-by-step clinical protocol for managing cerebral abscesses. We're taking a massive amount of clinical data and breaking it down logically, mapping out the entire patient journey, literally from the second they roll through the emergency room doors all the way to their long-term prognosis. Let's dive right in. Here is our roadmap for today. 1. Immediate management. 2. Antibiotic protocols. 3. Surgical options. 4. Aspiration and excision rules. 5. Essential cultures. And 6. Outcomes and prognosis.
Section 1. Immediate management.
Okay, so when a cerebral abscess is suspected, your very first 2 foundational steps are absolutely non-negotiable. Step 1, you've got to obtain blood cultures. We need to know exactly what we're fighting. Step 2 is initiating empiric antibiotic therapy, ideally right after a biopsy if one is happening quickly. Regardless of whether you ultimately go with a medical or a surgical treatment down the line, these 2 steps have to happen immediately. Now, the crucial point is this. You must avoid a lumbar puncture, or LP, in almost all cases of a suspected cerebral abscess. Why? Well, a cerebral abscess acts as a space-occupying lesion in the brain, which ramps up the intracranial pressure. Doing an LP can cause a sudden, massive shift in cerebrospinal fluid dynamics, which can lead to catastrophic brain herniation. So just remember, skip the LP. No exceptions. So, what about other immediate medications? It's really a tale of 2 drugs here. Anti-seizure medications are obviously indicated if the patient is actively having seizures, but using them purely just as a prophylactic measure, that's entirely optional. On the flip side, glucocorticoids, like steroids, are highly controversial. Yes, they brilliantly reduce life-threatening edema and slow down the fibrous encapsulation of the abscess, but there's a huge catch. They can actually reduce the penetration of our antibiotics into the abscess itself, and of course, they suppress the immune system. Because of this, steroids are strictly reserved for patients who are showing active clinical and imaging deterioration caused by marked mass effect. And if you do use them, you've got to minimize the duration of therapy as much as possible. Section 2. Antibiotic protocols. Before we know the specific pathogen, we have to hit the infection hard with a broad-spectrum triple-threat empiric therapy. First up is vancomycin at 15 milligrams per kilogram IV every 8 to 12 hours. The reason we use this is to aggressively cover MRSA. To that, we add a third-generation cephalosporin, which is typically ceftriaxone, although if the patient is post-surgical, you'd want to swap that for cefepime instead. Finally, we add metronidazole, 500 milligrams every 6 to 8 hours to wipe out any anaerobic bacteria. Now, if you're looking for an alternative to the cefepime and metronidazole combination, you can actually just use meropenem at 2 grams IV every 8 hours. Once those blood or biopsy cultures finally come back, we get to refine our attack. This is our targeted therapy phase. If the culture shows only streptococcus, we can safely scale back our broad coverage and hit it with high-dose penicillin G, either by itself or with ceftriaxone. On the other hand, if the culture reveals methicillin-sensitive Staph aureus, that's MSSA, and assuming the patient doesn't have a beta-lactam allergy, we swap out the vancomycin for nafcillin at 2 grams IV every 4 hours for adults. This targeted approach is fantastic because it spares the patient all that unnecessary broad-spectrum toxicity while zeroing in on the exact bug causing the problem. Sometimes, though, we face highly specialized pathogens that require some pretty unique regimens. For fungal invaders, things like Cryptococcus, Aspergillus, or Candida, the go-to protocol is liposomal amphotericin B coupled with flucytosine. And we have to be extremely vigilant with immunocompromised populations. For instance, in AIDS patients, Toxoplasma gondii is a notoriously common pathogen. For those specific cases, the initial empiric treatment has to pivot immediately to a combo of sulfadiazine, pyrimethamine, and leucovorin. Now, you might be wondering, how long do we have to keep up this pharmaceutical assault? Well, the standard duration is a grueling 6 to 8 weeks of continuous IV antibiotics. Actually, 6 weeks is what you'll see most commonly. But here's an incredibly important clinical nuance to remember. After that 6 to 8 week mark, you stop the IV antibiotics even if the CT scan is still showing abnormalities, like lingering neovascularity. Why would we stop? Because radiographic improvement almost always lags behind clinical improvement. The healing brain takes a lot of time to look normal on a scan again, even after the infection is totally defeated. So trust the clinical picture. The main IV phase has a strict, predetermined endpoint. When we're looking at those follow-up scans to confirm our therapy is actually working, success is defined by a visible decrease in 4 distinct areas. We want to see a decrease in the degree of ring enhancement, a decrease in the surrounding brain edema, less overall mass effect, and a decrease in the actual size of the lesion itself.
But a quick heads up, do not expect the size to shrink overnight. It typically takes anywhere from 1 to 4 weeks, with a mean of about 2.5 weeks, to see a real reduction. In fact, 95% of lesions that resolve with antibiotics alone will show a size decrease by the 1-month mark.
Section 3. Surgical options. All right, let's talk surgery. The neurosurgeon basically has 4 main tools in the toolkit for this. Number 1 is needle aspiration. This is the absolute mainstay of surgical treatment, and it's particularly great for deep, multiple, thin-walled, or immature lesions. Number 2 is surgical excision, which is where they go in and remove the abscess entirely. This is huge because it dramatically shortens the required antibiotic time. Number 3 is external drainage. This one's pretty controversial and honestly not used very frequently. And number 4 is direct antibiotic installation right into the abscess cavity. Historically, this hasn't been super effective, but you'll sometimes see it used as a total last resort for stubborn, refractory Aspergillus abscesses.
Section 4. Aspiration and excision rules. So, needle aspiration is usually performed using stereotactic localization under local anesthesia. But mapping out the trajectory of that needle, that is a high-stakes geometric puzzle. The surgeon has to adhere to 4 golden rules to prevent catastrophic collateral damage. 1. Explicitly minimize the path length through healthy brain tissue. 2. Never, ever traverse the ventricles, because spilling abscess contents into the spinal fluid causes a severe, life-threatening ventriculitis. 3. Completely avoid all vital neural and vascular structures. And 4. Do not drag the needle through already infected external structures, things like infected skull bones, scalp wounds, or paranasal sinuses. Doing that could literally drag brand new bacteria straight into the brain.
What happens when a patient shows up with multiple abscesses? Which one do you even go for first? Well, the protocol is crystal clear on this. If the underlying diagnosis is totally unknown, you target the largest lesion, or whichever one is causing the most severe neurological symptoms, just so you can get that initial culture. But once the diagnosis is confirmed and your IV antibiotics are running, you only aspirate remaining lesions if they hit specific criteria. They have to be 2.5 centimeters or larger in diameter, causing significant mass effect, or actively enlarging despite the medical therapy.
Now, regarding full surgical excision, you can't just do this early on. It can only be performed during the chronic phase, what we call the late capsule stage, where the abscess can be removed whole. Pretty much exactly like a well-encapsulated brain tumor. The massive benefit here is that a total excision of a mature, accessible abscess drastically cuts down the required antibiotic time. Excision is highly recommended for traumatic abscesses associated with foreign material that needs debriding, nocardia abscesses, fungal infections, or complex, multiloculated lesions that a simple needle aspiration just can't clear out. Section 5. Essential cultures. The second that aspirated material hits the pathology lab, an exhaustive battery of stains is required. It's real detective work. A basic gram stain is up first. Then an acid-fast stain, or AFB. This one is absolutely critical because Mycobacterium and the genus Nocardia resist decolorization, meaning they will strikingly appear red under the microscope while everything else stains blue. You also have to run a modified acid-fast stain looking specifically for the branching bacillus of Nocardia. And finally, special fungal stains like methenamine silver and mucicarmine are deployed just to ensure nothing microscopic is hiding from view. But remember, stains are just the visual check. Actually growing the organism takes immense patience. Routine aerobic and anaerobic cultures are standard. But a vital takeaway here is that fungal cultures must be specifically requested because the lab has to intentionally keep them for much longer periods. Why? Because fungal organisms are indolent and fastidious. They grow incredibly slowly. Discarding a culture too early means you might miss a fatal diagnosis. The lab also runs dedicated TB cultures and highly sensitive molecular PCR testing to hunt down the DNA of Mycobacteria, Epstein-Barr virus, and the JC virus.
Section 6. Outcomes and prognosis.
To put things into perspective, back in the pre-CT scan era, getting a cerebral abscess was almost a guaranteed death sentence, with mortality ranging from 40 to 60%. Today, thanks to advanced imaging, potent antibiotics, and stereotactic surgery, that mortality rate has plummeted down to between 0 and 10%. That is a massive triumph of modern medicine. However, the morbidity remains tragically high. Think about this. 45% of patients will suffer some form of permanent neurologic deficit, 27% will develop late focal or generalized seizures, and 29% will live with hemiparesis, which is weakness on one side of their body. So yes, we are saving their lives, but their quality of life is forever altered. Sadly, there are specific red flags that warn a clinician of a highly unfavorable outcome. A worse prognosis is strongly associated with poor neurologic function at the exact time of admission. If the abscess happens to rupture into the ventricular system, survival odds drop sharply because of the resulting catastrophic inflammation. And perhaps most sobering of all, if a transplant recipient develops a fungal brain abscess, the mortality rate approaches a devastating 100%.
As we wrap up this explainer, I really want to leave you with a profound thought. We've clearly mastered the art of drastically dropping the mortality rate. But with permanent neurologic disability hovering right near 45%, our work is far from over. So how will future neurosurgical innovations, perhaps involving nanomedicine or advanced targeted biologics, evolve to perfectly protect the healthy, delicate brain tissue while utterly eradicating these aggressive infections? It's really the next great frontier in neuroinfectious disease. And understanding the foundation we just covered, that is your absolute first step toward that future. Thank you so much for learning with me today. Keep questioning, keep studying, and I will see you in the next explainer.